Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
You're listening to
CRST
podcast
from Bryn Mawr Communications.
My name is Dr. Kevin Barber, and I'm excited to host this episode of the CRST, the podcast. Today, we'll be talking about addressing systemic gaps in ophthalmic care delivery through workforce development and global surgical mentorship. I have two guests, very distinguished guests with me here today, and looking forward to a very exciting conversation. So, first guest is Dr. Cynthia Matossian. She is the founder of the American College of Eye Technicians, known as ASET. Welcome, Dr. Matossian.
Thank you for having me.
Yeah, it's great to work with you. We also have Dr. Sara O'Connor. She is a fellow ACE Global board member with me and the co-creator of an ophthalmic technician training program that's being used in low to middle income countries in Honduras and has been picked up by Orbis and other organizations and actually is being used globally. So I think we've got some really exciting things to talk about over the next few minutes. I think the overall issue is that the need for ophthalmic care is rapidly increasing. We all know this. We've seen the studies and reports, the global demographic of people that needs our services is just rapidly expanding. But we as an industry are not really keeping up with training enough people, from the physician to the entire eye care team. And so today we'll be discussing some novel and innovative ideas on how we do a better job of training and innovating and teaching and bringing more qualified workers into the workforce. So let's start off, Dr. Matossian, talking about your great organization that you founded, ASET. I'm really eager to hear how you came up with this idea and how you brought it into reality. So please tell us about it.
Kevin, that was a great introduction, and you nailed the problem on its head. We don't have enough people to take care of all of the patients who need eye care. So the way I came about starting the American College of Eye Technicians, and we call it ASET, A-C-E-T, but pronounce it like a technician is an asset for every practice. That's how the play on words came about for the acronym to the way we actually say it. Because indeed, we don't have enough ophthalmic assistants or optometric assistants for that fact. Because people have not heard about this field, there's not a lot of career recognition for this, for people to kind of choose this as a career option and get involved. So what I started is an outreach program where we recruit adults. They have to be 18 and older and need a high school diploma or a graduate equivalency diploma. And we introduce them to eye care assisting. We call it eye care assisting because we don't want to scare them away with big words like optometry and ophthalmology. We chose that on purpose and then bring them into the fold. And I'll go over our training and our placement process in a little bit.
Fantastic. Well, that's a beautiful idea. I know in my 20 years of private practice, I would say the number one obstacle we faced on a weekly basis was having enough, trained technicians in the clinic, because the turnover is difficult, especially post-COVID, where the workforce transitioned into in-home work, so it just made it more competitive. And so what a great idea. Start offering, because it is a great career for people. Both in our clinics and with industry. And so what a fantastic idea. Please tell us more. So how do you recruit these individuals? How do you train them? How do you get them into the workplace?
Because there is such a shortage, as you said, we had to be inventive. And instead of poaching a technician from a competitor's or a friend's practice, I said what's missing is de novo talent coming into the field of being eye care technicians. So we work with high school counselors. We work with high school mentors. I learned there was such a thing. I was not aware of that. We worked with youth based organizations and through faith based organizations as well, and reach out to communities who are underserved or less privileged. And these could be young moms coming back to work. It could be veterans who've completed their service, their duty, but now don't know what to do in civilian life. Or it could be somebody graduating high school, not on a college track, but is considering maybe becoming a nail technician or a hairstylist. And now we're introducing a totally different field that literally, as you so well put, Kevin, the sky is the limit. It is an entree to a career. If somebody has that initiative, that drive, that interest, literally, they can become a CEO of a company, they could become a practice administrator, or swerve or pivot onto working with industry with additional training, of course. So it's a great way to encourage young men and women to enter the field, a field that they've never heard of.
That's really fantastic. That just reminded me. My current administrator, I hired 15 years ago as an entry level workup tech with no experience, and we trained her, and she did. She worked up, went and got her MBA, and now she's running, a multi-office, multi-surgery center, practice, and that's one of my greatest sources of pride is just seeing the development you can offer to these individuals by creating these opportunities. So that's absolutely fantastic. Sara, I might pivot to you for just a moment. Maybe give us a little insight from your perspective on the need for technician training or allied health training outside of the U.S. We know we're desperately at need inside the U.S. What's it like in these low to middle income countries that you're working in?
Our experience in Honduras has been a similar thing. We have this need. Ophthalmologists have such support needs. There's so many skills we need among our support staff. And there it's not even a question of can you find somebody, steal somebody from another practice? Like they aren't there. They're just so few being trained, so few technicians, ophthalmic technicians, nursing, sort of operating room assistants being trained, that we just decided in order to support our training needs for our fellows, we needed to start training technicians as well. And so we branched out into having a year-long process, and we bring in people with little or no background in it. Sometimes we take an RN, somebody who's had some nursing, and take them through our program. But yeah, it's just, and again, it's a way of giving them a skill that they can support themselves with. And it just opens up a whole potential career path if we can give them the skills, and we benefit from their just learning in our clinic. We're giving them the skills, but they're also supporting our process.
Been working with Sara, and we started there training ophthalmologists and training surgeons, and we very quickly realized, surgeons can barely make their own cup of coffee, much less, work up patients or have the assistance to be efficient, in the clinic and in the operating room. And so we couldn't really make a difference by training just the surgeon. We've got to create the whole eye care team. So I think the obstacle though is how do we identify, good candidates to bring into the field, which Dr. Matossian, your ideas are great. I mean, working with high school counselors, mentors, faith-based organizations, I mean, you're really tapping into where, the best candidates are. I think that's phenomenal. How do you then efficiently educate and train them? Because I think, as you mentioned in your article, what we most do is we hire somebody off the street with no training, and we stick them with our most senior tech and hope that after a few weeks or months, they figure it out. And what a terrible way to, to really train, because it is an emotionally and physically draining um, process for both. So enlighten us, what's a more efficient or better way to train these people?
What we do is once we get these young men and women enrolled, and our average age, we just have enough graduates now to have some statistical analyses, is about 24, 25. So they're not the 18, 19-year-olds who are joining our program, which is really wonderful. They have maturity and they are serious about what they want to do. We have an online 8-week program. It is one night a week for 2 hours. We purposely picked Monday nights because often some of our students have been waiters and waitresses, servers, and restaurants are closed often on Monday nights. So that's why we picked Monday nights. And it's facilitated by expert COTs and COMTs. They train. We go through a curriculum that we put together. It's very foundational. The students are graded on class participation, on timeliness of their homework assignments, of the quiz grades, and so forth. It's all broken down by percentages. They have about 4 to 6 hours worth of homework and reading material per week for each of the 8 weeks. And then after the 8 weeks, they take the final exam. We purchase the medical ophthalmic assisting book from the American Academy of Ophthalmology for every one of our students. And we purchase the key for the final exam, which these students take. And to date, all but one has passed the MOA test, medical ophthalmic assisting test by the AAO. And then we help place them into different practices based on where they want to work, which city they're in. And to date, our graduates have been from all over the US, literally from the West Coast to the East Coast, north to south, because it's a virtual online course.
Phenomenal. So my first question is, can we get that in Spanish so we can start using it in Latin America? Because I mean, maybe Sarah, I mean, those are just brilliant ideas, and I really applaud your work at putting this together, because you know, all of the techs that we tend to hire with no, I mean, they literally show up with no foundation. And that's just a hard place to start, because ophthalmic clinics are just fast moving machines, and it's a hard place to learn on the go like that. So I really applied the thoughtful way you've thought through that. And I would love to implement or see Sarah implement that in Honduras and in the low income countries. So Sarah, what thoughts do you have?
Yeah, I love the model of one night a week so that they can continue. They need to support themselves. And so they need to keep working in whatever they're working in while they do this program. And so I love the one night a week and the homework. And then I also love they can hit the ground with a lot of knowledge, and they need to still develop their skills, their hands-on stuff, but you've kind of front loaded all of that knowledge, and you don't need to take time in clinic to explain what the cornea is. They've got that, and then you can just work on skills. um, but it is really sensitive to the fact that they need to support themselves while they're doing this. And so yeah, I love this model.
Thank you so much. And actually, because they're front loaded with their didactic knowledge, their runway to integrate a particular skill, like you mentioned, Sarah, is very quick, because they've already been taught that they have to do visual fields for a disease state called glaucoma, and it's assessing the optic nerve. They know how to spell all these different words. So all they have to do is really figure out the how to run that particular visual field unit.
And right, just add in the few little skills, but they've got all of that background that you can depend on. That's a great model.
I'm sure all the listeners now that are in private practice are saying, how do we tap into this? Is there a way for interested practices, myself included, to be a part of your network, to where we could, have access to some of your graduates?
We would be happy to, but first, We are working on figuring out how to recruit smarter and how to recruit better. We're just learning how to do that. So, our next goal, actually, once we have enough money from donations and sponsorships, is to hire a full time bilingual recruiter, Spanish and English. And eventually, we want to add to that language to include multiple other languages. And to go to job fairs, to go to these places where they could recruit in person. We're just not there yet. And once we have regular graduates coming out, I would be happy to place them all into your practices.
Great. Well, we will stay connected and stay tuned. And I know that I can't imagine there's many practices in the U.S. that would not want to be connected to Asset. So thank you for bringing that to the marketplace, and what a tremendous impact it's making already and will continue to make.
Thank you very much.
All right, so why don't we shift now into talking about the other end of the spectrum of training, which is training surgeons. As I mentioned, my name is Dr. Kevin Barber, and I formed Advanced Center for Eye Care Global. It's a nonprofit that focuses on training fellows in low-income countries. We started with cataract surgery, but we are now branching out to other subspecialties such as oculoplastics, and then pediatrics and retina will be coming. What we observed is that in many low income countries, the residents graduating from their residency programs were trained fairly well clinically, but were not given the benefit of surgical training. And so some of our fellows come to us with zero surgical cases as a board certified, ophthalmologist in their country. And so we put together a training program that's quite intense, and again, primarily focused on cataracts because that's the leading cause of preventable blindness within our scope. And we put them through an intensive surgical year where they are able to do 400 to 600 cataract surgeries within that year's time. And then once they graduate, they can return to their country and actually be a very effective surgeon in trying to reduce the burden of cataract blindness. Um, and part of that training program, as we've been learning and going through our process, is doing something called distance surgical mentorship. So the biggest limitation in low income countries is that there's just not enough teachers. It takes time and it takes money to teach. And if you're in a low resource environment that doesn't have a Medicare that's willing to pay for physician education, or private hospitals that are willing to pay for private education for physicians, then it's really hard to find dedicated teachers because those physicians themselves are barely scraping by. So how can they donate or spend much of their time teaching their own residents or future surgeons? So what we do with this distance surgical mentorship, and this came out of our COVID experience, we typically recruit U.S. surgeons. We travel to Honduras, where our training center is. We have our fellows that come from all Latin American countries there, and the U.S. surgeons will spend 1 or 2 weeks, and they sit side by side at the microscope teaching this fellow, and that's how they would get their skill development. And now that we've been doing it for 7 years, we actually have Honduran faculty members that are our graduates, and so we're slowly working ourselves out of a job. And so what we do is for the first 8 months, our fellows get direct mentorship with an attending in the operating room with them. And then, as part of their process, the last 3 to 4 months, they go to a peripheral satellite clinic and they start doing surgery independently. And as we all know, that's the most anxiety-provoking time for any surgeon, when you sit down to do your case for the first time by yourself. And that's where we observed a drop-off rate where some will succeed and some will fail. And we want 100% of these surgeons to succeed because we desperately need them in these low income countries. So the distance surgical mentorship, what that does is it allows the fellow to use his own cell phone, use an adapter that's connected to his operating microscope. So now he can use the camera on his cell phone, start a Zoom meeting, and then invite a mentor anywhere in the world to join that Zoom meeting. And the fellow wears AirPods, and so he's operating, but the mentor can see the case, can see everything happening through the microscope, and can talk and verbally mentor that fellow. And so what that does, it just rapidly increases the number of teaching hours without being a burden to the local ophthalmic community. And we've recruited probably about 200 volunteers now between the United States and Europe. So now every time one of our fellows transitions into their first month or two of independent surgery, they've got someone looking over their shoulder virtually. They're able to ask questions. Um, some people say, well, gosh, if the attending's not there, how do you handle a vitrectomy? So we've already made sure they know how to do a vitrectomy. They know how to handle the basic complications of cataract surgery. But I can tell you, my first vitrectomy I did in private practice, I sure would have liked to have had, David Chang or some experienced guru sitting on my shoulder telling me what to do. That would have brought my anxiety level, way down. So that's, in a nutshell, the DSM uh, project that we've developed, and we actually did a study with Sara's help, where we demonstrated that by just doing DSM over 25 cases, that it increased a surgeon's Oscar scores, so an objective measure of their proficiency, significantly. And then it also cut their operating times almost in half. So we have shown that this can be a really effective way of teaching and trying to augment teaching capacity in these low income countries.
Yeah, I just want to add something. There's the stress of, is this person ready to operate independently? But I'd also note our fellows get about 500 cases over the course of their 1 year fellowship. So by the time we're transitioning them to DSM, they've probably done 250, maybe 300 cases with a mentor in the room. And so like they have a lot of experience before we even turn them loose to DSM. And so we do a really intensive training year, that then transitions to this a little bit more independent, but it's they get a lot of a lot of surgery in our program.
When a young surgeon is being kind of pivoted over to your DSM program, has the surgeon met his or her mentor, or is this the first time they're interacting together?
Terrific question. So that's been part of our learning process. Just like as Sara was mentioning, we learned very quickly you don't do DSM with residents, you don't do DSM with beginning fellows. They need to be comfortable enough handling, so you got to put the patient safety at first, right? Um, so normally, our most dedicated volunteer mentors are the same surgeons that have traveled to Honduras, that have met these fellows, that have a strong professional relationship, and they're excited to continue that relationship because they're not going to be able to travel to Honduras again for another year. But once a month, they can get on and see their fellow and, hey, remember, we do this now. Occasionally, we have fellows who will be mentored by a surgeon in Europe or other places that are just volunteers that they have not met person or face to face. So we usually recommend that they meet the night before to review the cases. They get to know each other a little bit. We also require that our new mentors observe several mentoring sessions because it's a little bit different skill. You can't just reach in and do something under the microscope. You have to learn the verbal skills of describing what you want done, which isn't difficult, but it's nice to see it done a few times first. So we require our mentors. Actually, we recommend that they do a wet lab. So we have virtual wet labs that we do with the residents. So it's on a model eye, so zero risk. So they start there, then they observe live surgery DSM, and then once they feel comfortable and they've met the fellow that they will be attending, reviewed the cases, then they do it. And usually the first time a new mentor is mentoring, we have an experienced mentor just watching, just to offer any support if it came up. And usually after that first session, we have not had any mentors say, "Ah, that was a terrible experience. I'm not coming back." They've all said, "Wow, this is really fulfilling. I'm glad I can do this from the comfort of my own, living room." So,
You've thought through every one of the steps. Commendable, really commendable program. Kudos to both of you.
well, thank you. I wish we could say we thought through the steps before we made the mistakes, but we didn't always do that.
You recognize them and now implemented a solution, which really deserves kudos as well.
Oh, thank you.
Yes, some of it's born out of necessity. We got there and training surgeons, oh, we need techs. And we've also, another thing that was, just put a plug in for our community health worker curriculum, we realized we needed to reach out to the communities through the community health worker program. And so we're educating, it was an existing program, but we created a whole eye unit so that now they have training in eyes and can hopefully refer patients from more remote areas who can't come for a check, get them in the pipeline of care. And so I'll just put a plug in for our community health worker program as well.
That's a great point, Sarah, and I think that just comes back to our kind of the recap of our highlights here. Is that really to be effective, no matter where we're working, whether it's in the U.S. or outside of the U.S., we have to look at the whole eye care team. We tend to get hyper focused just on one part of it, but from the community health worker to refer those patients in to the technicians to support the workup and the efficient thoroughfare of those patients to the surgeons who can do high quality surgery, each part of that's critical. And if any part of that machine is broken or not being fulfilled, then the whole system kind of breaks down. So this is really exciting to me to hear innovative ways of how each part of the machine is being improved upon and made more efficient. Our hope with our DSM project is that this is going to grow into a global platform that any academic institute, because there's many partnerships going, academic institutions in the US that are working with residency programs in Africa or Asia or Latin America. There's lots of nonprofits that are doing teaching like Orbis and Cure Blindness and See International. So I envision creating a platform where this DSM can be used by anyone, anywhere, and we add in an AI component that can do Oscar scoring of the videos. So the learning surgeon not only is receiving the mentorship, but then also gets a grade, and hey, here's and it starts to develop some standardization of skills that must be met, for surgeons, just like you're doing with your testing for, your technician students. You're giving them tests and you're making sure they're meeting certain qualifications before you release them into their practices. So what an exciting discussion. This is really motivating to me. Any other highlights or recaps that we should mention before we end the podcast? Anything highlighted for you too?
Kevin, I wish you lots of luck taking your platform globally along with you, Sarah, because just like there's a need in Honduras for technicians, I'm sure there is a global need for technicians. It's not country specific. So, lots of luck in expanding this program. Ultimately, the beneficiaries will be our patients. And that's what we want. We want less people suffering from curable situations like cataract.
I would just add that if anybody's interested in any of these materials we've developed in Honduras for educating technicians, we have a curriculum and testing and community health worker things. Please reach out. We're happy to share and spread the love because, like you say, the need is everywhere, and it's just we're happy to share and collaborate and build more partnerships.
Well, thank you both for your time and the great work you're doing in the world. For the listeners, if you'd like to get in touch, I'll give you the two websites. So for Asset, it's www.aceted.org. And for ACE Global, it's www.acecaresglobal, all one word, .org. So please feel free to log on. There's emails, info emails that you could get in touch with us there, if you would like to. Thank you so much. What a great discussion. It's really energized me, and I hope you guys have a great rest of your day.
Thanks so much.
Thank you very much.
For more shows like the one you just listened to, check out the podcast channel on itube.net.